Thank you, Quantel Medical, to give us the opportunity to share our knowledge, especially on COVID-19 and on lung ultrasound. I will present you the speakers. On the left, you can see Gervais Bagbode. He's with us actually. He will explain you all the ultrasound and CT scan comparison. He's a specialist on ultrasonography in Bordeaux, France. He works with us in MedTandem, which is the website where we promote the sharing between the doctors. You will see also lots and lots of images from Daniel Lichtenstein, who is a French doctor also. He's an intensivist. He wrote lots and lots of books on lung ultrasound use for ICU and especially for COVID-19. He was with us on all the Visio conference we did the next month. I'm Lucie Beylacq. I'm from France, also from Bordeaux. I'm an anesthesiologist, and I'm a specialist on ultrasound, especially in regional anesthesia and face and eye blocks. So actually, I will just go back on the disease, on the COVID-19 disease. I will just go back and explain you the disease like we all see. On the first week, we can see that there is really the virus part, which is we have all the signs like a viral disease. It's the specialty is the neural attack with the aguzy and the anosmia, but the other things, the other signs are really like the influenza or some other virus. Which is really different. It's on the second part, between the 5 and the 10 days. We have lots of new signs, and we can really see a very big difference. There is lots of interpretation of the mechanism of the second part disease, but the signs which appears are most important signs are the problem with the lung, which is not IRDS. We know that actually, but which is like an IRDS. This second part will really be seen with the CT scan, and we will explain you the real place for the lung ultrasound actually. In France, we organize the care for the patient with the sign. If the people have the signs, the viral signs like a fever, cough, anosmia, aguzy, sometimes digestive forms, we had or it was severe signs or it was not severe signs. If it was severe signs, we had all the comorbidities, you know, as usual, and you had also the severe signs. It was the first measures we have in France. It was maybe at the beginning of March. You will see that just after we said careful, the respiratory frequency upper than 22 was an alert sign. Like the oxygen saturation less than 94. Before we thought it was 92 and high frequency respiratory frequency like 40, but with the COVID it was really less. We had to intubate some patients with that kind of signs. We used to do the PCR test because these patients were at the hospital, were at the beginning or in the entry of the hospital. So if they had comorbidity or pregnant or were in a community for old people, more than 3 cases, they had the PCR and they had the CT scan to see all. On the other side, we had the patients who were not on the hospital. It was on the CT, and if they have no severe signs, no problem with the pulmonary, they were just locked down during 14 days. If they had suspicion of pulmonary sign, of course, they had lockdown also at home, and they had a follow-up evaluation at day 5 to 7, because we know that there is the break here in the disease, and the gravity can appear on day 5 and day 7. What was the images we saw with the scanner, with the CT scan, and what was the sensitivity of the nasal PCR test? It was not very good on the first days. We saw that the sensibility was 56% with the CT scan and also with the PCR. And after, we could have with both the PCR and the CT scan, a sensibility which is increasing. What was the lesion? We will talk about the lesion again after. That was ground glass, that was condensation, no adenopathy, and no pleural effusion. That was a really differentiation was there, no adenopathy, no pleural effusion. The evolution with the CT scan on the phase 1, we can see focal images. Day 3, we could have an extension with a new lesion, and sometimes an extension to the second lung. And after, on the phase 3, we had the condensation and the crazy paving-like images. For the lung ultrasound images, we could see the loss of aeration of the lung with the ultrasound, because we could see. I will explain you again all the images you can have with the ultrasound, but really simply, when the lung is black, there is a normal image. When it begins to be white, it's interstitial pneumonia, and it begins to have less aeration. And when the lung is like a tissue, is like it's an hepatization. You have the consolidation, and you have no more aeration, or very few. So that's the real problem. Where is the place for the ultrasound lung for the lung ultrasound? Sorry, actually in the COVID, we have very few data. I will show you a study, a French study, but on the others, it's more the experience of the people who use the lung ultrasound for every day to care the patient. And we have the proposition of the Italian, lots of papers for Italian people. Also, I will show you for the Spanish people who use the lung ultrasound, and say that of course it's you have to care of you. You have to be safe with the machine and the probe, and for you also. But the lung ultrasound reduce health worker exposition to infect patients. Could be repeated during the follow-up, is low cost, and is really easy to use without moving the patient.